I'm Julian Shah. I'm a consultant urologist and head of female and reconstructive urology at University College Hospital in London. Patients who develop incontinence of urine, their symptoms tend to fall into two different groups. The first group is the patients with stress incontinence. In other words, when I cough, I sneeze, I run, jump, laugh, I may leak a few drops of urine, or even more than that. Then on the other side, there are patients who have the urge bladder condition. In other words, I go more frequently to pass urine, I may get up at night to pass urine, or when I want to go, I've got to go, and if I don't go, I may leak. If we concentrate on the female with incontinence, it's a very common condition affecting possibly about 10% of the population. One of the principal causes, of course, is childbirth. So having a baby tends to stretch the pelvic floor, perhaps damage the nerve supply to the pelvic floor, so it makes the pelvic floor and the sphincter mechanism that controls the urine weak, and therefore the patient will leak when she coughs and sneezes, etc., as I've described before. The other condition, urge incontinence, is quite different and has different causes, age-related. Of course, some people may be born with a condition which the bladder is a bit irritable and can get worse throughout life. And there are neurological conditions such as spinal cord injury, multiple sclerosis, spina bifida, that can give rise to abnormalities of the bladder, which give rise to incontinence. Men tend not to suffer with incontinence as much as women because they don't have babies. So usually if a male becomes incontinent, he can become incontinent because his bladder is irritable, unstable, or the overactive bladder, and that can be an age-related condition. It also occurs in men who have prostatic obstruction, so as their prostates enlarge and the bladder becomes obstructed, the bladder can become irritable too, so not only do they not pee very well, they also can become urgent and urge incontinent. Now, we would normally investigate patients very simply, first of all, by doing a urine test. So we dipstick the urine to make sure there's no infection. We would want to get them to fill in a chart, how much they drink when they drink it, how much they pee when they pee it, because large fluid intakes, which is a common thing these days, can make people go more frequently. So the patient who presents with incontinence, having talked to the consultant about the condition, and the consultant said, well, this is the way we should manage your problem, and we always try to start with conservative measures. Conservative measures, for instance, for stress incontinence, would be pelvic floor re-education. In other words, strengthening the sphincter in the pelvic floor to hold the urine in. If a patient's got a problem with urgency and frequency, we try bladder retraining, and that's done with a continence advisor. We may also provide pills at the same time. So for the patient with a bladder that's urgent and frequent, or with urge incontinence, we would start with anticholinergic medication or antimuscarinic medication, and there are a number of drugs on the market that we can use to try to calm down the bladder spasms that cause incontinence. If the patient comes back and has had a trial of medication that doesn't work, or has tried pelvic floor exercises that don't work, and the patient is sufficiently distressed and incontinent to warrant some form of treatment, then we would offer surgery. And for patients with a significant weakness of the pelvic floor or prolapse, we can do an operation called a colposuspension, which has been around for about 40 years and is a very good operation to cure incontinence. If the patient's very bothered by their incontinence, in other words, their unstable bladder urgency incontinence is so troublesome that they can't cope with it, then we've been lucky in the last few years to have Botox, which people will associate with wrinkles in the face, but it's very effective when injected into the bladder wall. And it stops the bladder spasms, and it works for about 6-9 months, sometimes 12 months, and will help to cut down those spasms that cause incontinence, and they're very, very effective. There is a small risk, of course, with Botox because you weaken the bladder of pushing the patient into retention. In other words, they can't pee very well. Now, our incidence of that is about 10%. And we teach all our patients beforehand to learn how to drain the bladder, so at least if that occurs, they know what to do. For the patient with a very unstable bladder that responds to nothing else, then we can do more major surgery, in which we enlarge the bladder with a section of the intestine, which is also a very effective operation and cures about 90% of patients. Anybody with incontinence tends to find it very embarrassing. It's a socially restricting condition, and yet it's not a disease in the sense. So it's not life-threatening, you're not going to die from it, unless it's due to a neurological condition such as spinal cord injury, where there is a threat to your life, and most of these patients are managed in spinal injury centres. So if you have a problem with incontinence, the thing to do is to seek medical advice. The thing to remember is that everybody lives a long time these days, and this condition can go on for a very long time. So the most important thing is to make a diagnosis and try to offer appropriate treatment so you don't suffer in the long term with great distress.